Welcome to Lesson 3 of your antepartum unit. In this lesson, we will cover the concepts associated with gestational conditions that result in high-risk pregnancy. The objectives of this lesson will include explain the effects of hyperemesis gravidarum on maternal and fetal well-being, differentiate among the causes, signs and symptoms, possible complications, and management of miscarriage, ectopic pregnancy, cervical insufficiency, and high datiform mole. Compare and contrast placenta previa and placental abruption in relation to signs and symptoms, complications, and management. Review other gestational complications that can lead to a high-risk pregnancy. Hyperemesis gravidarum. In pregnancy, as many as 80% experience nausea and vomiting. The causes can be relaxation of smooth muscle and increased levels of the pregnancy hormones estrogen and progesterone and human chorionic gonadotropin. However, if vomiting is such that weight loss, electrolyte imbalance, nutritional deficiencies, and ketonuria occurs, this is hyperemesis gravidarum. Risk factors for hyperemesis include hyperthyroid disorders, pre-pregnancy psychiatric disorders, previous pregnancy complicated by hyperemesis gravidarum, molar pregnancy, multiple gestation with a male and female fetus, diabetes, and gestational disorders. Many have a family history of hyperemesis. Complications of severe hyperemesis include esophageal rupture and deficiencies of vitamin K and thiamine, resulting in Wernicke encephalopathy. It may be related to high levels of estrogen or HCG or associated with transient hyperthyroidism during pregnancy. Conflicting feelings regarding the pregnancy may also contribute to hyperemesis. Clinical manifestations are weight loss and dehydration. Assessment reveals dry mucous membranes, decreased blood pressure, increased pulse rate, and poor skin turgor. They may be unable to take liquids, even by mouth. Care management includes a complete and thorough assessment to determine the severity of the hyperemesis. A complete description of the frequency, severity, and duration, along with a description of the vomitus, needs to be obtained. Measure weight and vital signs. Check the urine for ketones. Other labs include CBC, electrolytes, liver enzymes, and bilirubin levels. A psychosocial assessment should be completed. Initial care includes IV therapy for correction of fluid and electrolyte imbalance. Medications may include paroxetine, vitamin B6 alone, or with doxylamine or Unisom. Other meds include promethazine, which is Phenergan, chlorpromazine, thorazine, prochlorperazine, compazine, metoclopramide, Reglan, and ondansetron, which is Zofran. Despite the commercials of attorneys, there is no quantifiable evidence that Zofran leads to birth defects. Once vomiting stops, feedings begin in small amounts at frequent intervals, beginning with oral fluids and bland foods and progressing slowly. Most women are able to take nourishment after several days of treatment. Hemorrhagic disorders in pregnancy. These are medical emergencies. They place the mother at risk for hypovolemia, anemia, infection, preterm labor, and preterm birth. They can affect the oxygen delivery to the fetus. Fetal risks include blood loss or anemia, hypoxemia, hypoxia, anoxia, and preterm birth. Now we're going to discuss early pregnancy bleeding. There are different types of early pregnancy bleeding, including miscarriage, reduced cervical competence, ectopic pregnancy, and gestational trophoblastic disease. With miscarriage, this type of early pregnancy bleeding is classified as threatened, inevitable, incomplete, complete, and missed. With a threatened miscarriage, there will be spotting, but the cervical os is closed. In A here, you see a threatened miscarriage. You see all of the products of conception, the baby and the placenta, still within the uterus. The cervix is closed, but there is bleeding. The inevitable and incomplete miscarriages, there will be moderate to heavy bleeding and mild to severe uterine cramping. Tissue may be present. An incomplete miscarriage involves passing the fetus but retaining the placenta. In B here, what you see is an inevitable miscarriage. All of the products in conception, the placenta and the fetus, are still within the uterus. However, the cervix is open. There is no saving this pregnancy. C is an incomplete miscarriage. What you have in the incomplete miscarriage is you still retain the placenta within the uterus, but the fetus is no longer there. With a complete miscarriage, all of the products of conception pass and the cervix closes. Slight bleeding may occur with mild cramping. D here is a complete miscarriage. You see the fetus wrapped in the placenta. All of the products of conception have passed. A missed miscarriage indicates that the fetus has died, but the products of conception remain in the uterus for up to several weeks. There may be no bleeding or cramping. E is a missed miscarriage. You see this, all the products of conception, the placenta and the fetus, are still within the uterus. The cervix is closed, so there is no bleeding. There's also recurrent or early or habitual miscarriage. This is 3 or more spontaneous pregnancy losses before 20 weeks gestation. The management of miscarriage depends on the classification of miscarriage. Expectant treatment with bed rest may be prescribed. Serial ultrasounds and measurement of HCG and hormone levels may be done. Further treatment depends on whether the threatened miscarriage progresses to actual miscarriage. If the products of conception do not pass, medical or surgical intervention is required. Prostaglandin medications such as misoprostol, Cytotec may be given orally or vaginally. Prostaglandins may cause nausea, vomiting, and diarrhea. If medical management does not work, or this may be the initial management, a dilation and curettage, D&C, may be done to remove the products of conception. With a D&C, analgesics and anesthetic may be given. After the surgery, oxytocin is given to prevent hemorrhage. For excessive bleeding after a miscarriage, ergonavine, methogen, or a prostaglandin derivative such as carboprostromethamine, hemabate, may be given to contract the uterus. Antibiotics may be given as necessary. RhoGAM will be given if the woman is Rh negative. The woman is usually discharged the same day within a few hours if her vital signs are stable. The need for rest is emphasized along with iron supplements if there was significant blood loss. The loss is an issue for most women. Refer the woman and her husband or partner to support groups. Reduced cervical competence is a case where the cervix dilates prematurely, leading to miscarriage or extremely preterm birth. It used to be called cervical incompetence in the past, which indicates an all or nothing. It has been discovered that there are varying degrees of cervical competence. Factors that can predispose for reduced cervical competence include previous cervical trauma or ingestion of diethyl stilbestrol, DES. Clinical diagnosis is based on history. A short cervix, one less than 25 millimeters, indicates a reduced cervical competence. Medical management includes bed rest, pessaries, antibiotics, anti-inflammatory drugs, and progesterone supplements. Surgical management with a cerclage may be done instead. The McDonald technique is most often the procedure of choice. A suture is placed around the cervix beneath the mucosa to constrict the internal os of the cervix. It is placed at 11 to 15 weeks and removed at 37 weeks. Follow-up care involves bed rest for a few days following their cerclage. The patient should be told to avoid sexual intercourse until after a postoperative check. After this, physical activity and sexual intercourse decisions are based on the status of the cervix. Here you see the method where there is sutures around the cervical os. Here you see a cross-sectional method of showing the sutures around the cervical os. Ectopic pregnancy. When the fertilized ovum is implanted outside the uterus, an ectopic pregnancy can occur in the tube, the interstitium, or the cervix. In ectopic pregnancy, the ovum can also implant in the abdominal cavity. There's increased incidence of ectopic pregnancy. This is thought to be due to the increased sensitivity of the beta HCG measurement and transvaginal ultrasound. Other causes include increased incidence of STIs, tubal infection and damage, and the popularity of contraceptive methods that predispose failures to be ectopic. Classification is according to site. Abdominal pregnancy could be carried to term, but carries with it multiple risks, including hemorrhage at any time during pregnancy and fetal pressure deformities. The clinical manifestations include abdominal pain, delayed menses, and abnormal vaginal bleeding that occur 6 to 8 weeks after the last period. Symptoms include abdominal pain that begins as a dull lower quadrant pain on one side. This progresses to a colicky pain, then a sharp stabbing pain, and finally a constant severe pain that is generalized to the lower abdomen. If the woman presents with one-sided shoulder pain along with deep lower quadrant pain, suspect ruptured ectopic pregnancy. Colon sign may also be present, indicating hematoperitoneum from an undiagnosed ruptured ectopic pregnancy. Every woman who presents with abdominal pain, vaginal spotting, or bleeding and a positive pregnancy test should be screened for ectopic pregnancy. A quantitative beta HCG levels and transvaginal ultrasound are diagnostic. Beta HCG levels that are greater than 1,500 milli-international units per milliliter, but no intrauterine pregnancy is seen, as ectopic is likely. Beta HCG levels will be drawn every 48 hours to determine viability. Progesterone levels may be checked. A progesterone level of greater than 25 nanogram per milliliter rules out ectopic. A level less than 5 nanograms per milliliter suggests ectopic or abnormal intrauterine pregnancy. Management may be either medical or surgical. Medical management involves administering methotrexate to dissolve the pregnancy. In order for methotrexate to be successful, the mass must measure less than 3.5 centimeters with no fetal cardiac activity and a serum beta HCG level of less than 5,000 milli-international units. Surgical management involves either a salpingectomy or a salpingostomy if the woman desires to maintain fertility. Follow-up care involves encouraging the woman and her family to share concerns and referral to a grief, loss, or infertility support group. Gestational trophoblastic disease. Hydatiform molar pregnancy is a benign proliferative growth of placental trophoblasts in which the chorionic villi develop into edematous, cystic, avascular, transparent vesicles that are grape-like clusters caused by abnormal fertilization. As you can see here, this is what the grape-like clusters look like. The incidence and etiology: 1 in 1,000 pregnancies are molar pregnancies. The cause is unknown. Risk is increased if a previous molar pregnancy or in early teens or older than 40. The types are a complete mole in which an egg was fertilized that did not have a nucleus or it was lost or inactivated, and a partial mole. Demonstrates a particular karyotype on chromosomal studies. It results from 2 sperm fertilizing a normal ovum. The clinical manifestations: early can't be distinguished from a normal pregnancy. Later, 95% of the cases have vaginal bleeding. It may be dark brown like prune juice or bright red and either scant or profuse. Uterus may be significantly larger than the due dates indicate. Anemia from blood loss, excessive nausea and vomiting or hyperemesis gravidarum, and abdominal cramps are seen. Women may pass the vesicles. Diagnosis is accomplished using a serum HCG levels and a transvaginal ultrasound. Management: most abort spontaneously, but if not, a D&C may be done. RhoGAM should be given if the patient is Rh negative. Follow-up care involves frequent physical and pelvic exams with weekly beta HCG levels until the levels decrease to normal and remains normal for 3 consecutive weeks. Next, let's discuss late pregnancy bleeding, starting with placenta previa. In placenta previa, the placenta is implanted low, near, or completely covering the cervical os. Classification is based on the degree that the internal cervical os is covered by the placenta, either complete, where the placenta completely covers the cervical os, marginal, where the edge of the placenta is 2.5 centimeters or closer to the cervical os, and low-lying. With a low-lying placenta, the placenta is low to the relationship of the cervical os, but how close cannot be determined. In this slide, you can see two different types of placenta previa. In slide A, you see the placenta completely covering the cervical os. There's placenta on both sides of the cervical os. In B, you see the placenta barely reaching the cervical os. So this placenta is a complete and this one is a marginal placenta previa. Placenta previa occurs in 1 in 200 pregnancies. Risks include previous C-section birth, advanced age greater than 35 to 40 years, multiparity, history of smoking, living at a higher altitude. Incidence is more frequent with male fetuses and with previous placenta previa. The cardinal symptom is painless, bright red vaginal bleeding during the second and third trimester. It is usually diagnosed by ultrasound prior to bleeding occurring. Vital signs may be normal despite heavy blood loss. A decrease in urinary output is a better indicator than vital signs of blood loss. The uterus is usually soft, relaxed, and non-tender. The major complications for the mother is hemorrhage. She may require hysterectomy because of the uncontrolled vaginal bleeding. Other potential complications include the complications associated with a cesarean section. Fetal complications include fetal death due to preterm birth, stillbirth, malpresentation, and fetal anemia. Also, intrauterine growth restriction. Diagnosis is considered anytime there is painless vaginal bleeding after 20 weeks gestation. Diagnosis is confirmed with a transvaginal ultrasound. Expected management includes observation and bed rest. Initially, the patient will be hospitalized. If bleeding decreases, activity may be increased to include bathroom privileges and moving around the room 15 to 30 minutes 4 times each day. If no bleeding occurs for a 48-hour period, the patient may be discharged for home management. Active management is instituted if the patient is greater than 36 weeks and is in an immediate C-section. The nurse should continuously monitor the patient while prepping for surgery. Blood loss may not stop with the birth of the infant. Emotional support is necessary. The nurse should allow the patient to express her feelings openly. Next, we'll talk about late pregnancy bleeding. First is abruptio placenta. Abruptio placenta is detachment of part or all of a normally implanted placenta from the uterus after 20 weeks gestation. Abruptio is the cause of 1/3 of the cases of antepartum vaginal bleeding. There is an increased risk of abruption if the mother has hypertension, either chronic or gestational. Cocaine can cause an abruption. This causes a vascular disruption in the placental bed. For those who do not know better, it is thought that cocaine induces labor. It does it by causing an abruption. Not a good idea. Other causes include abdominal trauma, usually from an MVA or battering, smoking, previous history of abruption, preterm prolonged rupture of membranes, inherited or acquired thrombophilias, and a twin gestation. Classification of abruption is based on grade 1 mild, grade 2 moderate, and grade 3 severe. The abruption can be partial, complete, or marginal. This picture shows the 3 different types of abruption. The first abruption, you have a partial separation where you just see the little area right here that is separated. This is a concealed hemorrhage. If the blood continues to go, you will find a hard area on palpation over the area of the abruption, and the mother will complain of pain. A partial separation, you'll see apparent hemorrhage. You see a portion of the placenta has separated. The remainder remains intact. Again, you will see a buildup of blood with pain and hemorrhage. This is a complete separation and a concealed hemorrhage. The placenta is no longer attached at all. If the baby were here, what you would have is no oxygen getting to the baby. The baby needs to be delivered immediately. If vaginal delivery is unable to be accomplished, a C-section will be performed if the mother does not have problems with clotting factors. The clinical manifestations of abruptio vary with the degree of separation. Vaginal bleeding, abdominal pain, uterine tenderness and contractions are noted. Also of note is mild to severe uterine hypertonicity. Pain may be localized over one region or diffuse over the entire abdomen, which is board-like. Shock may occur with bleeding. A positive apt test may be done to discover blood in the amniotic fluid. Clotting defects may be noticed, progressing to DIC. A Klein-Hauer-Betke test may be done to determine fetal to maternal bleeding. This test detects fetal hemoglobin in the maternal blood. Abruptio can lead to hemorrhage, hypovolemic shock, and hypofibrinogenemia and thrombocytopenia in the mother. In the fetus, intrauterine growth restriction and preterm birth, as well as neurological defects and cerebral palsy. In the case of a complete separation, fetal death can occur. Diagnosis of abruptio placenta is not accomplished using ultrasound. Ultrasound does not detect all cases of abruption. It's usually confirmed after birth upon examination of the placenta. It should be suspected if the patient complains of sudden onset of intense, localized uterine pain with or without vaginal bleeding. Expectant management is used if the patient is less than 34 weeks gestation. The mother may be hospitalized, or maybe, if no bleeding, may be at home and monitored. The woman should be monitored closely for extension of abruption and appropriate fetal growth. Active management. The goal of active management is immediate birth of the baby. A large bore IV should be started of 16 or 18 gauge. Vital signs should be done frequently to assess for declining hemodynamic status. Serial labs including hematocrit, hemoglobin, and clotting studies are done. Continuous fetal monitoring should be instituted. Indwelling catheter is inserted for continuous assessment of urinary output. The patient may require fluid and blood replacement. Vaginal birth is preferred due to the risk of clotting difficulties. However, a cesarean may become necessary. Cesarean should not be considered if the woman has severe, uncorrected coagulopathy. Emotional support is important because a woman and her family could be experiencing loss. This concludes this lesson. There are other high-risk gestational conditions that you can review. These will not be included on the antepartum unit exam.